Good afternoon, everyone, and welcome to this briefing session on Fit for the Future. We will provide a high-level overview of the programme, but this session really is focusing on proposals to do with acute medical take. And I have a few colleagues with me this afternoon to help share the benefits of that proposal and answer some questions. So we'll just do some brief introductions. My name is Simon Lansley. I'm Director of Strategy at the Hospitals Trust and the overall exec lead for the Fit for the Future programme. If I could just introduce my colleague Steve.
Thanks, Simon. Hello, good afternoon, everybody. My name is Steve and I'm the Director of Quality and Chief Nurse.
And Ian, please.
Yeah. Hi, everyone. I'm Ian Shaw. I'm a consultant gastroenterologist and Chief of Service for the Medical Division.
And Rob.
Good afternoon. So I'm Rob Stacey. I'm an A&E consultant. I'm the clinical lead for our emergency departments. And that means that when I'm working a clinical shift, I work in our departments in both Cheltenham and Gloucester.
Great, thank you. So the purpose of this session, as I said, is a bit of an overview of the programme and a bit of a deep dive then into acute medicine proposals. A chance for you to ask questions. So we've had some questions sent in before the session, and you should see at the bottom of your screen a link to Slido with an event code #AcuteMedicine, and you can send in questions throughout this session and we'll pick them up and between the four of us cover those. And within that, again, I guess some ideas, if there's any suggestions you think we may have missed and views on the changes, it would be great to hear those. So the format of the session, we're going to share a short video now, which is from our medical director, Professor Pietroni. And then between the four of us, we'll share some slides to pick out the key points, and then we'll focus on some questions. So Matt, can I ask you to play the video, please?
Our ambition is to provide world-class, leading-edge specialist hospital care for our patients. Our expectations of healthcare, the demands on the health services, and the incredible progress made through science and technology have dramatically changed the environment that we're operating in. This means that we need to do some things differently. Thanks to the great work of NHS and care staff, we're well on the road to outstanding, but there's more to do. That's why we've been involving staff, patients, local people and the public in looking at a number of services and potential solutions. Following extensive engagement with staff, partners and the public, which included a citizens' jury and a solutions appraisal in public, we're now preparing to consult on a number of options for some services across our sites. We will use a variety of methods and approaches, including a virtual online consultation. The aim is to improve health outcomes, reduce waiting times and the number of cancelled operations, and ensure people see the right specialist to meet their needs 24 hours a day, 7 days a week. It's important that there are always strong and safe staffing levels across our services. We support joint working between related services to reduce the number of visits people have to make to hospital, and we attract and keep the best staff in Gloucestershire. For our services, it's about developing our Centres of Excellence approach, which reflects the way a number of services are already concentrated in one place, such as cancer care in Cheltenham and children's services in Gloucester. For our hospitals, it's about developing to 2 thriving, vibrant district general hospital sites in Cheltenham and Gloucester, with strong identities, both providing world-class leading-edge treatment. The potential solutions we outline in Fit for the Future consider whether one hospital should focus more on emergency care and one hospital should focus more on planned care and oncology. We believe this could help to ensure that the right facilities and specialist staff are always available to give people the best treatment and care. It could reduce the number of planned operations cancelled when beds or operating theatres are needed for the most urgently unwell patients. We want to strike the right, but often difficult balance between having 2 world-class centres of excellence in Gloucestershire and providing local access to services. There are no proposals to close Cheltenham A&E or to change the current staff arrangement, which includes consultants, doctors, nurses and allied health professionals. Full facilities for resuscitating, stabilising and treating patients would continue to be in place. Last year, we ran a comprehensive programme of engagement, and together with you, we explored the opportunities and challenges of developing specialist hospital services. We developed ideas and potential solutions for change, and designed the criteria we would use to assess those potential solutions. We now want to consult with you about how we could organise some specialist services. Acute medicine, gastroenterology inpatient services, general surgery, which means emergency general surgery, planned lower gastrointestinal or colorectal surgery, and planned day case surgery. Image-guided interventional surgery, sometimes called IGIS, including vascular surgery, and trauma and orthopaedic inpatient services. For more information, please visit onegloucestershire.net or register with our new engagement platform, where you can share your views, experiences and ideas about health and care services at getinvolved.gloss.nhs.uk.
Thank you. So I'm hoping people can see some slides now. I just wanted to pick out a few points from that presentation and then lead into the questions. So Fit for the Future is about the medium to longer term strategy for the Trust, and thinking about how we use our two hospital sites, so Cheltenham General and Gloucestershire Royal. And the aim really is to focus on that world-class leading edge specialist hospital care. So we're aspirant, we want to be competing with the best in England, but we know it's difficult to strike that balance sometimes between having centres of excellence and providing local access to services. But we think the configuration of services that we've come up with help provide that. You may remember earlier in the year, so back in August all the way through to February, we had an engagement programme. So we ran a number of events where with public and the staff, which has helped inform this shortlist. And some key messages we got back from that engagement programme was around that people were supportive of the Centres of Excellence approach. So particularly around that repatriation of activity so that Gloucestershire residents could be treated within Gloucestershire. And they saw the benefit of establishing Centres of Excellence to help us to continue to attract and retain the very best workforce in Gloucestershire. And some of this we already have in place. So you'll be familiar with our cancer centre, our oncology centre at Cheltenham General, and the centralisation of paediatrics, for example, at Gloucestershire Royal. So it's building on some of that work that we've already done. So the vision is this, a groundbreaking specialist hospital for Gloucestershire, but operating out of two sites. It's about turning the NHS long-term plan into action. So there's lots of talk in the press around the continued separation of emergency and planned care and all the benefits that can bring for patients and for staff. So it's about turning that into action for us. And as I said, we've already centralised some services. So I talked about paediatrics, but also gynecology. We've centralised at GRH, and alongside oncology and urology at Cheltenham General. But in most cases, the way services are configured across the two hospitals is down to history rather than design. So this programme is about using those principles of the long-term plan around a greater separation of emergency care from planned care, and thinking about how that helps us to use our two sites to the best ability. It's really important to note that this is not a purist model. So what we're not saying is all emergency activity at Gloucestershire Royal and all planned care at Cheltenham General. And you see that within our commitments to Cheltenham A&E, for example. So we said that service will revert to as it was pre-COVID. So it will be consultant-led between 8 a.m. and 8 p.m. and a nurse-led unit between 8 p.m. and 8 a.m. But similarly, in critical care, we've committed to maintaining a 24/7 critical care unit at Cheltenham General, because that will enable us to continue to do that complex planned care activity through the site. So please try not to think of it as a pure all emergency at one and all planned at another site. So in terms of a definition of a Centres of Excellence, there's 5 or 6 bullet points here. I'll just pick out a few of them, but to help bring it to life, for an emergency centre of excellence, what we mean is where life and limb threatening conditions come to a single site, so they have access to the right specialist team, facilities and equipment 24/7, and all those services are co-located so they can work together. So for example, we'll have acute medicine alongside our trauma team, alongside our general surgery team, alongside our interventional radiology team. And that's all about providing rapid senior assessment for patients. So we stabilize, we diagnose, and we treat those patients as soon as we can to give the best chances of survival and recovery, again, to provide that best-in-class service. And this option around emergency care is where we think we can deliver that plan to repatriate activity. So currently, some patients have to travel to Bristol or Birmingham or Oxford to access some of these specialist services. And we think in centralising services and teams and equipment onto these two sites, Gloucestershire residents can be treated in Gloucestershire. And primary PCI is a good example of that. So if patients that have heart attacks, heart conditions overnight currently have to go down to Bristol, and by creating a centre of excellence for emergency care in Gloucestershire Royal, we want those patients to be treated within Gloucestershire. And in terms of planned care, that greater separation of planned care, and by planned care, for example, we mean hip operations, knee operations, cancer operations. By separating that from the provision of emergency care, it means that we can remove that competition for diagnostics, for example. So getting patients access to CT and MRI scans and beds and theatres. So our theatre lists at Cheltenham General will be, they'll run 52 weeks a year, they'll start on time, and they'll have all the equipment, kit and equipment they need. And if we're able to do that, if we have that greater separation, we think that will reduce delays and significantly reduce cancellations where you get that competition for capacity. Other things you see on this slide around quality and safety of care benefits. So again, if you centralize services onto a single site, you can reduce that unwarranted variation. So you can standardize some of that provision of care. I talked about getting that quicker assessment and decision making. And one area, particularly around acute medicine, we want to improve is the time it takes to get a senior decision review once you've been admitted. And there's a 14-hour national standard for that, and we want to improve our performance against that area. And as I said, those highly skilled teams working together, so the right clinical services on the same site, so they can access each other and ask for help, support for diagnosis and treatment. Lots of things have driven this proposal. So to pick out a few, for example, we don't have the staffing that we need to provide those, to continue to provide those specialist services across both sites, particularly in a 24/7 provision that we want to deliver. At the moment, you don't always see the right specialist first time. So a good example of that is in emergency general surgery, where you have a 50% chance of seeing the right specialist. So for example, if you come in with a condition that you need to see an upper GI surgeon, so an upper gastrointestinal surgeon, 50% of the time you'll see that. But the other 50% of the time you'll see a lower gastrointestinal surgeon, so a colorectal surgeon. And by putting that service onto a single site, it means that we can run two rotas. So the upper GI and the lower GI rota both run 24/7. So you see the right specialist 7 days a week. And that's one example of the benefits that we think we can get from creating these centres of excellence. Another area is around kit and equipment. So as the NHS adopts more innovative technology, that specialist high-tech equipment comes at a cost. So we want to get this long-term strategy agreed, so then we can make decisions about where we invest in that kit and equipment and the sites on which we locate them. We think there's a risk if we don't do this. So if we did nothing, we think we could fall behind other hospitals. So there's a risk that our services and our staff may consider to move elsewhere. There's an impact on some of our training provision. So again, centralizing services means that we can support our trainees better because those senior decision makers are around on site longer. I talked about that reducing patient travel, so making sure that Gloucestershire patients are treated within Gloucestershire. And that key separation, again, back to the NHS long-term plan, that separation of emergency care from planned care would help us to reduce cancellations. This summarises some of those outcomes, those aims of the programme. So about improving outcomes, about reducing waiting times, reducing cancellations, timely assessment, ensuring that we're always staffed to a safe level. So centralising services, as I said, enables us to pull those teams together so we can improve the robustness of our rotas. We want to continue to attract and retain the best people in Gloucestershire. So Gloucestershire is a really nice place to live and work, and we want staff to stay with us. And by a way of doing that is creating these centres of excellence so they can grow in their careers and develop in their time with us. And part of that is a way to increase our research and our training and our education. So it's not just a programme about putting services on individual sites. It's about how those services are delivered and the research and training opportunities that go with that. So we didn't sit in a dark room and come up with these proposals. I've mentioned the NHS long-term plan, but this shows a wide range of guidance and research and policy and best practice that we've used to inform these proposals. And one I wanted to pick out in particular is the South West Clinical Senate. So this is an external review by doctors and nurses and therapists from outside of Gloucestershire. And it's a key checkpoint that programmes like this have to go through before we can proceed to consultation. And the purpose of that checkpoint is to confirm that we've taken into account all that national guidance and best practice, and to confirm that our models are deliverable. And the South West Clinical Senate were really supportive of all the proposals that we've put forward. They did give us some advice and guidance, which we've incorporated into the models. But it was a real good kind of checkpoint that we needed to pass before we were able to come to this next stage. Equally, the feedback that we received, as I mentioned at the beginning, from staff and patients have also informed our shortlist around that repatriation, the adoption of new tech and equipment, and the real desire to attract and hold on to the best staff. So this is the detail of the options that we're consulting on. So the outcome of the work over the last 18 months or so. The blocks you see in red, we have one preferred option. So all the feedback we've taken, all the advice and guidance, we're consulting on a single option. And then the bits in blue at the bottom, we have two options. So the bits that we have a single option are to centralise the acute medical take at Gloucestershire Royal and to run that alongside the emergency general surgery and trauma. And you may remember that we split trauma and elective orthopaedics two and a bit years ago as a pilot. And this process is about formalising and making that change long term. To also establish a 24/7 interventional hub, so an image guided interventional surgery hub, which is where interventional radiology, interventional cardiology and vascular surgery work together and you use less invasive surgical techniques to provide care. And then over at the Cheltenham General site, so that separation of planned care, again, gastroenterology was a change we made a couple of years ago, and we've seen huge benefits from that service being on that planned care site, and we now want to consult on that becoming a permanent change. We want to move more day case general surgery onto Cheltenham General alongside elective orthopaedics, so those specialties benefit from that, as I said, that kind of consistent access, reliable access to beds and theatres and diagnostics to deliver that elective care. We want to establish an interventional spoke, so a service there that will support oncology and would support urology. So those are the fixed elements. And then the bit where we didn't come to a preferred option and we want to hear feedback from staff and patients and the public is around elective colorectal, so the lower GI service. And there's two innovative and deliverable options there. You could locate colorectal on the emergency site alongside emergency general surgery and upper GI, or you could locate it on the planned care site alongside urology, gastroenterology and gynae oncology to create a pelvic resection centre of excellence. And there's two views within the team. Both are deliverable, both would be an improvement on the current model, and we welcome feedback on that one in particular to inform our decision making when we get to that within March. I think it's important to say what this part of the Fit for Future programme is not about. So we made it very clear around our commitment to Cheltenham A&E, and as I said, that would revert to as it was pre-COVID-19, so a consultant-led unit between 8 AM and 8 PM and a nurse-led unit 8 p.m. to 8 a.m. And another other temporary service changes that we made recently in response to the COVID-19 pandemic. So those were made to help us manage that pandemic, and that was about reducing the number of access points in the hospital so that we could manage those three key pathways: COVID positive, potential COVID, and non-COVID. But that was to manage the here and now. So Fit for the Future is about the medium to longer term strategy. And as I said, we would then use that, once that strategy is agreed, we could make plans around the way we use our estate and our workforce and our kit and equipment to deliver it. So this consultation process will run from now until the end of December. It's followed by a citizens' jury in January, as broad as we can make it. But the role here is for us to listen and understand. So we're in listening mode now to see what you guys think about some of these proposals that we've put forward. And there's a broad range of ways that we're asking people to get involved, which we'll summarise at the end. So that hopefully gives you a broad overview of the programme and all the different changes. This session today is a focus on acute medicine. And we've got a couple of slides we're going to share, but we've just got another introductory video that I'm going to ask Matt now to play, just to lead us into the acute medicine section, please.
Acute medicine services work alongside but are separate from the emergency departments. Patients can be referred here by their GP, paramedics, senior community nurses, or from the emergency department. They provide assessment, investigations and treatment for patients with particular complaints such as breathlessness, severe headache, chest pain or frailty. The acute medicine team coordinates initial medical care, whether you need a hospital stay, also referred to as the acute medical take, or are able to return home after assessment and treatment.
We are facing many challenges, but we believe that there are opportunities too to enable us to provide the best possible care for our patients. Patients are not always seen by senior doctors as quickly as they could be. Rising demand for the services and increasing numbers of people with more complex needs means our patients often need to see different specialties when they are in our hospitals. We are struggling to recruit enough medical and nursing staff to fully staff both hospitals and meet the needs of all our patients. We need to timely communicate our decisions to primary care. We need more space to follow up discharged patients in an outpatient clinic-like environment. Our preferred option to achieve all this is to centralize the acute medicine take at Gloucester Royal Hospital.
Cheltenham General Hospital would continue to have a consultant-led A&E open 8 a.m. to 8 p.m. and a nurse-led service from 8 p.m. to 8 a.m. 7 days a week, providing a wide range of emergency services and able to resuscitate, stabilise and treat patients as required. Walk-in patients would be able to access the service as before. Many patients attending A&E can be diagnosed and treated the same day and return home. Sometimes this involves coming back to hospital for a follow-up appointment at either Cheltenham or Gloucester hospitals. If you are assessed by the clinical team at Cheltenham Hospital A&E or Gloucester A&E, need a hospital stay and can safely go straight to a specialist ward at either Cheltenham or Gloucester hospitals, you would continue to do so.
If you have a serious condition or your diagnosis is uncertain and need to be assessed urgently by acute medicine team, you would be taken to Gloucester General Hospital if not already there.
By making changes, we can ensure patients are able to see the right specialist first time and receive a more timely assessment, diagnosis and treatment when they arrive at hospital. We will also be able to attract more staff and provide more robust cover 24 hours a day.
We believe that these changes can offer safer care for the patients. By concentrating staff, doctors, nurses, physiotherapists and clinical staff at Gloucester, we can optimize our service provision to provide a world-class acute medical unit.
Visit www.onegloucestershire.net for more information. Register with our new engagement platform where you can share your views, experiences and ideas about local health and care services. getinvolved.glos.nhs.uk.
Okay, so we just got a couple of slides to pull out some of the key messages there, which I think we've probably covered this one enough. Rob, is there anything else you wanted to say around the emergency service provision?
I can only just describe that this is, we shouldn't confuse the temporary changes we have made for our COVID response, and this is what I look forward to returning to, and that is that I will work clinical shifts both in Gloucester Hospital, and I'll be emergency medicine consultant working in Cheltenham Hospital from 8 AM to 8 PM, and we will have the right skills and people to be able to meet the demands of those people who attend Cheltenham.
Okay, thank you. Ian, I think you're going to cover these ones, please.
Yeah, thank you. Sorry, I feel like Chris Whitty now. I need to ask for my next slide. In terms of the, there we go, thank you. In terms of acute medicine, I think the question of what is, it was answered to some extent in the video. It was a really good video. It is quite complicated to explain, but essentially acute medicine is a specialty that sits next to emergency medicine, it's sort of next to the emergency department, looking after patients with acute presentations of things like breathlessness, chest pain, so the initial assessment of people with heart attacks, stroke, acute neurological problems, intestinal problems that aren't surgical, so people who come in with bleeding from their intestines, with complications like liver problems, diabetes, a whole range of quite ill patients at times, pneumonia, these conditions. And the acute medical team are absolutely specialists in that initial assessment piece. Sometimes the whole of the care, they're very skilled in managing the whole pathway, but also the interface between the specialists. So if you come in with a heart attack, the acute medical team will be very good at managing the first part of that heart attack, but will then link in with the cardiology team, the heart specialist, to manage the rest of it. So it's a very key sort of team in the hospital. We receive a large number of admissions. The majority of those, well, there's a mixture really, but a large of those are predetermined by patients who've been to see their GP but are deemed needing to come into hospital, and obviously another proportion would come through the emergency department as an initial presentation. They work very much as a collaborative team alongside the nursing team, the therapy team, and other support services, and linking in with the specialists. So that's essentially to describe that, and I can perhaps take some more questions on that when we get to the question side. But so it's really the acute side of anything that's not surgical, trauma, gynecology, or paediatrics that needs that assessment beyond the emergency care department. So if we go to my next slide, if that's okay. Hope that will come up. There we go. So I'm not seeing my next slide on my screen. There we go. Thank you. Sorry. So what our current service, and this is pre-COVID really, because we have, for COVID, we changed it, but our historic and our current service on which we're consulting is we had an acute medical assessment service in both Gloucester and Cheltenham, as outlined there. In Gloucester, we tended to call that the acute medical unit, and in Cheltenham, just to distinguish it, it was the acute care unit, but very similar functions. Both sides had what we call same-day emergency care. So these are ambulatory walk-in assessments for patients who are slightly less unwell and don't necessarily need to stay in hospital. In Gloucester, they were open 8 to 10 and some weekend presence, but in Cheltenham, there was a weekday presence, Monday to Friday, 8 AM to 6 PM. So similar kind of services, slightly longer hours on the Gloucester side. The difference really is we had a couple of subspecialties that were available through the Gloucester site historically. So that included frailty. So that's care of really the very elderly patients who are not necessarily unwell for any one reason, but just because they're elderly, and relatively minor illnesses can cause them to decompensate and need care. And there's a real specialty area around that. And also stroke was managed predominantly through the Gloucester site, where all our stroke care was directed. But other than that, historically, patients could go to acute medical side in Cheltenham with the similar conditions they could do at Gloucester. So if we go to the next slide, which hopefully will appear, thank you. The proposal that we've been want to engage on and been consulting on is to move the assessment part of the acute medical service to predominantly be on the Gloucester site, to centralise that onto the Gloucester site. This same day emergency care aspects will continue on both sites, and that's quite important. And in particular, we'd be looking to extend the hours of the provision in Cheltenham to make that a longer service. So for those patients who don't necessarily need to come into hospital, who can be assessed in an ambulatory way, there'll be a greater provision on the Cheltenham site to support emergency care. And also an option, which I think is covered on the next slide, which is to have more direct admission through into for specialty patients into the Cheltenham site. But the benefits of this really are that centralisation, the critical mass that we can offer, that you saw coming through in the video, the extra specialty services, the way we can put all that in one place to extend the hours of consultant provision, to provide much greater senior review, much faster senior review, to really build on the care that we're currently providing, to harness that in a way that is difficult and has been challenging to deliver across two sites, while still maintaining the ability for patients to be seen on both sites and managed. So that's essentially what we're consulting on. I think go to my next slide there. So I think, do you want me to talk about the challenges and benefits, or is that going to be Steve's slide?
Oh yeah, Steve, do you want to cover that?
Thanks, Simon, and you, Simon, Ian, and Rob have kind of highlighted some of the key aspects of this. But Simon's detailed the rising demand in more of us requiring more complex care, and that real desire, importantly, to be seen by a senior consultant within 14 hours of coming to hospital, which is incredibly important in terms of improving outcomes for our patients. And I think it's clear and fair to say that many of us will require many different specialties in many different types of doctors, nurses and therapists to look after them whilst they're in hospital. And of course, the other challenge is ensuring that we recruit enough medical, nursing and therapy staff to ensure that we can deliver that aspiration about delivering truly exceptional and outstanding care. But what we already know in Simon and Rob and Ian have talked about this largely is, for us, it's principally about improving the outcomes of our patients and the people of Gloucestershire, and also improving the working lives of our colleagues as well. It means that we'll be able to attract more staff, and we have some really good evidence of where we have been able to think about the way that our services are delivered. It's starting to attract really high caliber doctors, nurses, therapists and others. The other important thing is it's about providing a more robust, resilient service. And when you have two types of services split on two different sites, sometimes that can be a bit more tricky. There's better supervision, better learning opportunities for doctors, nurses and others. And principally it's about being seen by the right consultant, the right specialist at the right time. So improving health outcomes for our patients and the people of Gloucestershire are really what's driving some of the key aspects around quality for these changes. Very happy to move on.
Great, thanks guys. So the proposal we're asking you to consider in this session around the acute medical take is to sort of establish a centre of excellence for acute medicine at Gloucestershire Royal. And I think we've been quite clear around the proposals to maintain the A&E department at Cheltenham and how acute medicine differs from emergency medicine. So at this point, just to pick out a few questions really. So we've had a couple that have come in online and a couple that were presented beforehand. So one of them is around timings. So if approved, how long before the changes can happen? So that one is probably about 18 months, 2 years away. So as I said, this is more about the medium to longer term strategy for the Trust. And if these proposals are supported, then we move into planning to making them a reality. And some of that will need to expand our estate. So we may need more beds on one site and more theatres on another site, for example. in our workforce, we may need to get some training programs in place to support some of those services on each site, and to make some decisions around equipment. So once we know where the services are going to be, there will be a lead time to procure and implement that equipment. So we're working on an implementation of probably about 18 months to 2 years before these range of changes would be implemented. Another question's come in, might be for Rob, this one. Rob, it's around, said you talk about same-day emergency care. What do we mean by that, and what sort of services would be provided on either site?
Yes, I can answer that. If you are or have been a current or previous user of our trust, you might have come to a department we call AEC, or Ambulatory Emergency Care, but the language that you'll see more commonly throughout the NHS is same-day emergency care. And a clinical example of that might be if you were to develop discomfort when breathing with breathlessness, and you needed investigation for a chest infection, or to see if you even had a blood clot on the lung. There are established pathways where you could attend our same-day emergency care department and have a clinical assessment, investigations that might include x-rays, or even indeed a CT scan, blood tests, and have the whole of your care managed on a same-day outpatient basis from the hospital. Whereas the traditional model would be you'd be attending through the emergency department or through a medical ward, and that may involve overnight stays. So it's that same-day emergency care where traditionally you'd have had a hospital stay.
Great, thanks, Rob. Another question is around benefits for staff. So I wonder whether, Ian, you could just think about the benefits for consultant colleagues and junior doctors, and Steve for nursing. So the question is around staff have had to deal with a lot recently. How will these changes benefit them?
Yeah, thanks, Simon. I mean, I think first thing to say is this is very much supported by staff as a proposed move. And when I joined the trust 18 years ago now, or nearly 18 years ago, one of the benefits was our size. With our population of 650,000, we have a real critical mass on which we can base it. And one of the challenges that's become increasingly clear is to be delivering acute medicine across 2 sites has actually limited our capacity to do some of the changes, to harness some of the benefits we want. So by pulling the staff together in this way, we can provide a much more robust, extended senior cover. So we can have extended consultant hours, which would be much harder to deliver across 2 sites. For example, we can have another medical registrar, so that's a reasonably senior, but just short of a consultant, on call 24 hours a day. When we can do that in one area, we can still provide support in Cheltenham, but we can strengthen the support, and we can pull the specialties together in a way that's much easier. So it's a lot about the efficiency of delivering the care and being able to pull those specialists together in a way that is much harder to do when you're fragmented across 2 sites. And as I say, we're fortunate in the county because we are the main trust that serves the whole of a large population, effectively about 1% of the UK's population.
Great, thanks, Ian. And
no
for
benefits
nursing?
being in one place.
Good, thank you. And for nursing, Steve, benefits for nursing teams?
Yeah, thanks, Simon. I mean, it's very similar to what Ian was describing for doctors. And I think, I mean, it's fair to say that acute medicine is a really interesting clinical specialty. It provides huge amounts of opportunities for learning, particularly for our junior nurses as they start their career. So it's great for training. It also means that it has better resilience. So invariably, as you have more services in one place, it allows for better resilience. You know, we have had some challenges in Gloucestershire, like many organisations across the country, in terms of recruiting. But what we have seen where we develop slightly bigger services, it starts to attract people. So better resilience. And the other opportunity which we have started to develop fairly extensively is around new roles for nurses, new roles for therapists. And when you're part of a centralised team, as we have described, and you know, acute medicine is incredibly interesting, it enables us a better opportunity to be able to develop those roles as we go forward.
Great, thank you. Another question that's come in is, have you considered building one new hospital to replace both Gloucestershire Royal and Cheltenham General? So you may be familiar, that, so within our Gloucestershire 2050, so the county-wide strategy, there is a statement in there that says by 2050 we'll have a new hospital for Gloucestershire. But as a trust, we're aware, that's 30 years away, and we can't wait that long. So this strategy is about improving care, looking for the next 10, 15 years. We're aware that the country is coming out of austerity, so the ability to access the amount of capital that would be required to build a new hospital, again, within the medium to long term, we don't see that as a viable option, but we continue to explore that as a trust clearly. But we think doing nothing until we wait for that long-term solution is not the right thing to do. So this is about improving care now, thinking about a 10 to 15 year horizon. So that's the focus at the moment. There's a question coming around, what would the preferred option mean for patients presenting at Cheltenham A&E? And I'm thinking around, that what we would continue to manage within Cheltenham A&E, and if that patient did need to be transferred to Gloucestershire Royal, how would that happen? So I wonder, Rob, would you just explain a little bit about how that could work?
Yes, I can answer that. So the people you would meet who would assess your medical need would be the same people you would meet before these changes, and indeed their staff who rotate through Gloucester Hospital as well. So in terms of the clinical expertise that would be available in Cheltenham, then that will be matched. I spoke earlier in response to another question about same-day emergency care. So there would be the opportunity to manage those patients who might need additional tests or slightly sort of follow-up investigations through that service. But if you were to require admission, then there will be some specialties on site in Cheltenham where you might be able to have a direct admission. But if you needed the centre of excellence and the service had been located at Gloucester, then we would transfer you to Gloucester. And whilst I should be clear that the temporary service stage changes that we have at the moment are temporary, and this is separate from that, one of the things we've learned from that temporary change is that we've been able to transfer patients swiftly and safely from the Cheltenham site to the Gloucester site when needed. So I hope that answers the question fully.
Yeah, thanks, Rob. Just one other question that's come in, which just a reminder, if there are any more, please do use the Slido link to send those in. Is now the right time to consult during a pandemic? And we've thought very long and hard about this, and it was discussion we had with our colleagues in the Health Overview and Scrutiny Committee as well. But we feel that delaying these benefits any further is not the right thing to do. So hopefully you've felt from this presentation, there's huge benefits to patients of implementing these changes, and we felt that delaying it is not the right thing to do for patients or for staff, because there is some uncertainty. So as I mentioned, a couple of these services are running in pilot form. So the trauma and orthopedics and the gastroenterology service changes have been running for a number of years now. So to continue that level of uncertainty and delay the delivery of benefits, we didn't think was the right thing to do. We took advice from the Consultation Institute, who are helping us with this consultation, independent group, and also NHS England. I mentioned the Southwest Clinical Senate as a gateway. We also had an NHS England gateway check before we proceeded to public consultation, and with NHS England we laid out our plans that we're going to run over the next couple of weeks, and how heavily we are going to use sessions like this, for example. So, historically, these would have been in village halls and community centres, and not great attendance. And I can see we're into the teens here. So it's good that we can be more flexible in the use of digital sessions like this. And we've got the online surveys, we've got the booklets, we've got drop-in sessions, we've got the open bus that is travelling around, and all the materials are available in different languages and in easy read versions as well. So we've been we've kind of broadened the way that we've sort of encouraged people to get involved in this, and all those things come together. We felt it was the right thing to do, and as I say, that approach was supported by NHS England as well. Okay, that's all the questions we've got come in. So unless there's any others, I'll hit refresh one more time. No, okay. So just to wrap up then, this is the kind of ways I've just summarised some of these in terms of getting involved in what is now a socially distanced consultation. So getinvolved.glos.nhs UK is a new online platform that we have. So where you can comment on the proposals. There's the link there to the surveys. You saw a number of films in this presentation, and those are all available online. And this session we focused on acute medicine, but there are other sessions running around general surgery and image-guided interventional surgery. For those people that are not happy using online, there is we can do a telephone interview. So there's a telephone number 0800 0151 548 where you can leave a message, and one of our team will call you back and get your views on some of the proposals. The tour bus, socially distanced and compliant tour bus is around, so a way to drop in and provide your views. And then internally with our own staff, so this is a staff engagement as well as a public engagement. So clearly staff have been heavily involved in developing these proposals, but there's 8,000 of us, so we now need to go to the next level and get everyone's voice. And there's several sessions that we're running internally within the hospital as well. So this consultation session is running until the 17th of December. All the feedback then gets collated into an output of consultation report. There's a second citizens jury that's run in January that will take the output of that consultation report and then make recommendations to the NHS board. So effectively taking back everything that people have said and to highlight these are the key things that need to be taken into consideration to make a longer term decision. And the hospital and the commissioner boards are meeting in March. So March is the decision time for whether these proposals become longer term, and particularly that decision I mentioned around colorectal, what's the long-term location for colorectal surgery as well. And that session on the 11th of March will also be live streamed on the internet, so people can see that decision-making process. Okay, so thank you for those of you that joined us online. I hope you found it useful. Thanks to my colleagues, Steve, Rob and Ian.
Thank you.
Enjoy the rest of your day. Thank you.